you come see about me. I'll be alone, dancing with no one. Tell me your troubles and doubts, giving me everything inside now. Well, love string so real in the dark. Think of the tender things that we were working on. The slow change can pull us apart. When the light gets into your heart, baby, don't you forget about me.
Wonderful, Chris. Absolutely.
Don't you forget about me. Will you stand above me? Look my way, but never love me. Rain keeps falling, rain keeps falling. Will you recognize me?
Okay, well, why don't we come in, grab a seat, and we will keep moving forward. So the next hour and a half, I'm going to talk about assessing decision-making capacity in the adult protective services clients that I see. And although it's APS, it's kind of APS specific, is based mostly on the work that I do with adult protective services. The truth is that decision-making capacity issues transcend all of aging and are certainly not specific to just adult protective services workers. You know, how often do you think I have a family member who comes to my clinic and says, can my dad still drive, right? Can he still manage his money? What do you think about him staying at home by himself, right? So it goes beyond just adult protective services. In this group, we'll talk about the process of decisional capacity assessments. I want you to understand some of the reluctance that some, not all, but some primary care physicians have that can really, I've just found that can really frustrate a lot of family and other professionals. So we'll talk about kind of primary care physicians and their role in this, and then describe the relationship between executive function and self-care abilities. All right. So again, those of you not familiar with how adult protective services regions are laid out, here's the map. We are in Region 11 right here, right? So Ann directs the Region 11. I live in Region 8. Region 8, the directorship is in Bexar County. Region 8 stretches from Del Rio on the river to Port Lavaca on the coast. There's 28 counties in that area. And every Wednesday, Adult Protective Services picks me up, and away we go into South Texas to root out decisional incapacity in the clients that APS serves. So, that's what I do. That's my job. And so we can begin by talking about sort of the scope of the problem. So, how many elders are there in Texas? How many elders are how many elders older than the age of 65 in Texas? No? One or two? A million? Several million? Okay. How many, let's just skip down to the end. How many guardianships are there in Texas? How many people in Texas are under a guardianship? Do you know? How many people would you guess are under a formal legal guardianship in Texas? 52,000. There's 52,000 people under a guardianship in Texas. Is that a lot? No? I thought I heard someone say yes. It depends on your perspective, right? It depends on your perspective. So in Texas, there are 2.9 million people over the age of 65 in Texas. If you look at those with a formal disability in Texas, there's 1.7 million between the ages of 18 and 64. You can see that in fiscal year 2013, APS completed 69,000 in-home investigations. And you can see that in Texas, there's 52,000 guardianships. So if you add the number of elders to the number of disabled, and then you take 52,000 and divide it by that, you get 1.1%. So 1.1% of all elders and disabled are under a guardianship in Texas, 1.1%. And so the challenge that Adult Protective Services and the Department of Aging and Disability Services has when it comes to guardianship is that depending on the lens that you're looking through, guardianships are either incredibly common or they're incredibly rare. And so this is very similar to suicide and suicide risk assessment in psychiatry, right? So in psychiatry, if you look at the CDC, suicide is always the 10th or 11th leading cause of death in the United States is suicide. The 10th or 11th leading cause of death in the United States is suicide. It's always 10th or 11th, depending on the year. And so you say, wow, the 10th cause, the leading cause of death, suicide, it's way too common. But the rate of suicide is actually 14 per 100,000. So 14 out of 100,000 people will commit suicide. 14 out of 100,000. So psychiatrists, what we have to do is try and figure out who are those 14 out of 100,000, and then try and figure out what we can do to help them, right? That's our job, is to try and help them. You know, whereas dads and APS have to figure out who are the 1.1% that need a guardianship. So depending on your perspective, guardianships are either too common or too rare. I think most people, when they see that it's only 1% of this group, a lot of times when I present that information, there'll be someone in the audience who will then think that perhaps guardianships aren't common enough. So it depends on your leanings here. So when Adult Protective Services takes me out, these are the questions they want me to answer for them. These are the questions. These are all in-home assessments, right? These are all in-home assessments that we're doing. They pick me out, they take me to the client's home. They want to know, does the client have a psychiatry diagnosis? They want to know, does the client have decision-making capacity? They want to know, what level of care do they need? Do they need an assisted living level of care? Nursing home level of care? Do they just need provider services? Do they need any care at all, in fact? Maybe they're independent, they don't need any help. And then the last thing that APS wants me to answer is the situation so bad? Are the living conditions, or is the person's physical health so bad that it poses an imminent threat to them, and that elder should be removed from their home today, taken to an emergency room, medically cleared, and then placed in usually a nursing care facility until the judicial system can sort out the need for guardianship? Okay? Those are the questions they're asking me to answer. So how long do my assessments take? How long would you guess it takes me to answer those questions? What's that? 45 minutes? A couple hours? Yeah, usually about an hour and a half. So all of this is decided in a one-time visit in about an hour and a half. There's no going back. Okay, there's no, well, I see how they are now. Why don't we come back next week and see again? These are one-time assessments, okay, that in about an hour and a half. So the first thing is that if you're doing capacity assessments, you have to know that capacity is defined by state law. And I can tell you, a lot of physicians, they don't know that. They actually don't know that capacity is defined by state law. In their mind, they have an idea of what capacity is, and they kind of base their decision based on what they think capacity is, but they're not doing it according to law. So what I always tell people is that if you're ever going to ask a physician to do a capacity assessment, give them a copy of the law, because chances are they don't know. They just don't know. So in Texas, an incapacitated person is an adult who, because of a physical or mental condition, is substantially unable to provide food, clothing, or shelter for himself or herself, to care for their individual's own physical health, or to manage the individual's own financial affairs. And you might like that definition. You might not like that definition. I can tell you, my opinion of the definition does not matter, right? That's law. Okay, that's Texas law right there. So if I say that someone does not have capacity, or that they do have capacity, I have to be willing to go to court, swear an oath, and testify that they meet or don't meet this definition. Okay, that's what I'm having to testify to. And I always tell people that the most important words in this definition are the verbs. The most important words are the verbs. So it's not does the client have food, right? It's, are they able to provide food, right? It's not do they have money, it's are they managing money? Are they managing money? Just like it's not do they have healthcare problems, it's can they care for their healthcare needs, right? So the most important words in the definition are the verbs. Okay. So this kind of, you can imagine that this introduces all sorts of ethical, legal questions. So we can talk about these. So the first is, should the client be notified that I'm coming? What do y'all think? Should the client be told ahead of time that APS is going to show up at their door with me? What do you think? Some say yes. I see some heads. And I see some say no, right? So kind of a mixed opinion, right? It's kind of a mixed opinion. So for this question, I always defer to Adult Protective Services. I defer to Adult Protective Services. And APS knows their clients better than, certainly better than me, better than most, right? APS knows their clients. And Adult Protective Services knows that there are some clients where if they tell them that next Wednesday they're going to bring the doctor, they know that that client is going to wake up at 7 a.m. They're going to take a shower, they're going to do their hair, they're going to have their makeup on, they're going to have a nice pot of coffee waiting for us, right? They know that. And they also have some clients that they know if they say, I'm bringing the doctor next Wednesday, if that client lives in Del Rio, they will be in Eagle Pass, right? They know that too, right? Okay, so for that question, I always defer to Adult Protective Services on that. But once we're there, do we tell the clients the purpose of the evaluation? We tell them why we're there. We did. So people agree that maybe we do. We don't just say, hi, we're here to check on you. See how things are going. No, we don't do that. So what we specifically do, this becomes an ethical and a legal issue. So we tell the client exactly what we're there for, and we also tell them it won't be private. We have to. If I don't tell the client that this assessment is not confidential, then it can't be entered into court. It can't. I have to check a box saying that the client was notified that it wasn't confidential. So I have this spiel that I always give. You know, I always introduce myself. I tell them who I am. I tell them I'm a physician. I work at the Health Science. And I have this introduce myself. You know, I tell them that I don't work for APS. APS doesn't work for me. We work together. When APS has medical questions about their clients, they ask me to help answer those questions. And these are usually questions related to their clients' abilities to make decisions, related to their memories, related to their ability to care for themselves, and that's what I'm here today. I tell them. And then I also say that normally when you're talking to a doctor, it's private. Today it's not going to be private. Today the report will go to Adult Protective Services. So if I ask you any questions that you don't want to talk about, you don't have to. I won't get mad at you, you won't hurt my feelings, we'll just move on. I tell them that. And after I've told them that, what is the most common response? It's not get out, it's not see you later, it's, Doc, you can ask me anything, I'm an open book. And that's when I know they don't have capacity. Right? 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 Because if I went to your home, unannounced, and I told you that I'm with the state, I don't work for the state, but I'm with the state agent, we're here to assess your decision-making capacity, you don't have to talk to me, and nothing we say will be private, what would you do? You'd say, get out or see you later, right? That's what you would say. But that's not what happens. It's almost always, Doc, you can ask me anything, I'm an open book. So we do tell them about the purpose. How much information should I get from Adult Protective Services? And is APS biasing my... So when I first started going out with APS, they were I've been doing this since 2008. So since March 2008, I've been collaborating with APS. So when I first started doing this in 2008, they didn't want to bias my opinion. They didn't want to give me as much information. They didn't want to bias. What do you think of that? Is that right? Yeah? Maybe? Yeah, I don't like that. Actually, I need Adult Protective Services to give me everything. I need them to tell me as much information as they possibly can. because that information is what I'm going to use to guide the interview. Without any information, I can't guide the interview. You know, I can't guide it, okay? So I actually need adult protective services to tell me as much as they possibly can about their case so that I know that this client has disability, so that I'm convinced that they're not providing food, clothing, or shelter, managing their finances, or caring for their health care needs. I need to be convinced that there's a disability, that they meet the disability component of the definition. And then I can guide the interview and decide, are they not doing these things because of a mental condition, like dementia, or are they not doing these things just out of free will, right? There's lots of reasons why people may not manage their health care needs, right? There's lots of reasons why people may not manage their finances, right? When was the last time you balanced your checkbook? Oh. Right? There's lots of reasons why they might not. But what I'm trying to figure out is, are they not doing those things just out of free will or because of dementia? Okay. All right. So I try and get as much as I can from APS. Should the capacity assessment be done by a physician unknown to the client, like me? I don't know any of these clients. Or should it be done by the client's primary care doctor? Who should do this? Me, who doesn't know them, or the client's primary care doctor? So someone says the client's primary care doctor. I heard you. Okay, so let's talk about that. So let's talk about me. So why am I maybe the better person to do these assessments? So unbiased, objective, maybe more objective. Okay. Trained in capacity assessments. I'm a geriatric psychiatrist. That's what I do. Right? Maybe those are reasons. Okay. What are reasons that maybe I'm not the best choice? Maybe the primary care doctor. Why would the primary care doctor be the better person? Because they know the client's history. They have a longitudinal relationship with them. They have the rapport. Yeah, they have the rapport. So those are all the reasons. What I can tell you is that adult protective services would love it. They would love it if the primary care doctors would give them this information. They would love it if the primary care physicians would give them the opinions. But a lot of times they just can't get those opinions out of the primary care doctors. They just can't. Okay, they just can't. All right. So then, is the primary care person the best person? The other thing I'll hear is that when I do an assessment, again, my assessment takes about an hour and a half, 2 hours. So in a year's time, how much time might a primary care physician spend with a patient? So say they had 3 visits in that year. How many visits does the primary care doctor spend with the patient for the whole year? Sometimes not, sometimes it's the PA, maybe it's 10 minutes, maybe it's 20 minutes. So time, yeah, you gotta, you know. So, you know, should they have to do it? You know, so what are the reasons why primary care doctors, I can tell you primary care doctors, most of them, not all of them, I work with a ton of great primary care doctors, but I can tell you, most of them hate this. They just hate it. So why not? Why do primary care doctors hate capacity assessments? They don't want to put themselves on the line. What do you mean by that? Liability? Okay, so there's not really liability, but there is going to court. Okay, so they do not want to be drawn in the court, right? Primary care doctors do not want to testify in court. They're not trained to testify in court. If they go to court, they have to close down their clinic for half a day. You show up to court, you just close your clinic down for half a day, and then the judge postpones the case. Right? And they just hate that. They don't like being asked questions by attorneys. They just don't like that. Nobody does, right? But they really don't like that. They feel like they have to defend themselves, and it's just too adversarial for them. They don't like it. Why else might primary care doctors not like doing this? They don't get paid. That's exactly right. So you can only bill Medicare for delivering medical services. This is not the delivery of a medical service. This is a forensic assessment. It's a forensic assessment. So we're not billing, you can't bill Medicare. Okay? So they don't get paid. So they don't get paid to do it. And then, if they have to close their clinic down, they're going to lose money, right? So it's like insult to injury, if you will. So it's a forensic assessment. I'm always very as transparent as I can possibly be about this. So I work for the University of Texas. The University of Texas contracts me out to Adult Protective Services to do these assessments. So because I work essentially for the state through the University of Texas, because APS is a state agency, I'm always as transparent as I can possibly be about the finances. UT bills Adult Protective Services $300 per hour for my assessments. That's what they bill. So if it's an in-county assessment, it's like $600. That's what it is. For in-county, it's going to be $600. But if we're going to Del Rio, it's 3 hours there, it's 3 hours back. It's however many assessments, right? So these can get expensive. And so the primary care doctors don't do that, right? They don't bill, right? They don't do forensic assessments. Why else might they not like to do these? Yeah. Word of mouth. They might. So what you're suggesting is word of mouth, they might lose the whole family. I think what you're suggesting is that these assessments might fracture the relationship that they have with their patients. And I think that's the most important reason, actually. So people who go into primary care, doctors who go into primary care because of the relationships that they have with their patients and their patients' families. And it may not necessarily be this way, but it can feel this way. It can feel like when you're doing capacity assessments, you're no longer working with the patient. It can feel like you're working against them. And so you're turning a therapeutic relationship into more of an adversarial one. And that's just not why they went to primary care, right? And so a lot of primary care doctors will say, you know, I don't know, can you ask a psychiatrist to do this assessment? They just don't want to fracture that relationship. So we've listed lots of reasons why they may not want to, but I do truly believe in my heart that most primary care doctors, the reason they're so reluctant is they just don't want to fracture that relationship. They, as y'all said, they could have been working with a client for the last 20, 25 years, and they just don't want to do that. And I think that's interesting. Okay, so when it comes down to it, I may not be the best, but sometimes I'm the best that people can do. So might be what my wife would say about me. Okay, so here we go. All right, so now what we have to think about is you have to be functionally impaired. And so to be functionally impaired, we have to kind of start to think about how we measure function. So how are we going to determine if a person is not providing food, clothing, or shelter, managing their finances, or caring for their health care needs, right? So what are ways to assess functional status? How can we assess functional status? So we can watch them. That's right. We can ask them. Right? We can just ask them. Ma'am, can you cook? Yes, I can. Ma'am, can you drive a car? Yep, I can drive a car. So you can do self-reports, right? So what's the problem with self-reported functional status measures? It might not be accurate. So what we know in epidemiological samples is that elders will over-report their ability. We know that. In epidemiological samples, elders will over-report their functional abilities. We know that. So maybe instead of asking them what they can do, maybe we just ask someone else. Maybe we ask their daughter, what can your mom do? We ask their son, we ask their spouse, we ask someone else what they can do. So that would be like a proxy report, right? We're going to ask someone else about their ability. What's the problem with that? It might not be accurate. In what way might it not be accurate? It may not be irrelevant. I'm sorry, say that?
Yeah.
They may be out for their money. Right, so in epidemiological samples, what we know is that caregiver reports of functional ability tend to overestimate disability. You get statements like, my mom can't do anything. I have to do everything. When in fact there are things that the elder can't do. Right? When in fact there are things the elder can't do. And so, so the idea of caregiver burden influences the assessment. But what we see in adult protective services sometimes is exactly what you're saying, which is we'll get statements like this. We'll get statements like, oh yeah, my dad can manage his money. He can manage it fine. He knew exactly what he was doing when he wrote me that check for $50,000. Yeah, he's good. Nothing to worry about here, right? Okay, so there's problems with self-report. There's problems with proxy report. You know, I can tell you what we do is we'll challenge them with a task. We do performance-based assessments. So part of my assessment is I have these like a bill. So I'll have them read a bill, demonstrate how to read a bill, how to demonstrate how to write a check for the bill, demonstrate how to read a check register, use a check register. I have this little phone book that I carry with me. I'll give it to them. I'll have them demonstrate to me how they would use the phone book to look up different numbers. So I do a couple of performance-based assessments. But what's the problem with that? What's the problem with performance-based assessments? They may not know how to use a phone book ever, maybe. Okay. They might not ever use a check. Test anxiety. Yeah, the real problem with performance-based assessments is that you're measuring what a person can do when they're told to do it, but you're not measuring what they actually do. Okay? So I have an 11-year-old son. What I might tell Kevin at 7 a.m. before he goes to school is, Kev, when you get home, I want you to clean up your room. Okay? And then I come home. Is the room clean? No, the room is not clean. So then what will happen? So then I'll go up and say, look, Kevin, the first thing you're going to do is you're going to pick up all the clothes. And then he'll pick up all the clothes. And now you're going to make your bed. Now you're going to put your baseball stuff away, whatever it is, right? So he can clean his room when he's told to do it, but he never cleans his room, right? So we're measuring, so that's the flaw. So the only way to really assess functional status is to live with a person for a year and see what happens. But I don't have that kind of time, and I'm not brave enough. So I think what's important to know is that there's lots of different, there's a lot of challenges with assessing functional ability. The other issue is cognition. So we assume that cognition is related to functional ability. We assume that as memory declines, people become less functional. But is that true? Is that true? And it's actually not true. And so there's lots of different cognitions. We've already gone through a whole bunch of them. Memory, orientation, language, math, visual, spatial, but executive function. So executive function is the cognition that predicts functional ability. It's the cognition that predicts functional ability. So we talked a little bit about this in the first hour, but now we're going to really talk about it. So executive function is that those cognitive processes that allow you to behave independently from your environment instead of having your behaviors controlled by the environment. When people become executively impaired, they become trapped by their habits, they become trapped by their routines, and the environment starts to control their behaviors. Okay? So if you are an elder in a nursing home, what does the doorknob tell you to do? Turn it. Right? The doorknob tells you to turn it. And you turn the doorknob, and now there's a long hall. What does a long hall tell you to do? Walk down it. And then you walk down the long hall, and the doors go psh. What does that tell you to do? Walk through them. And now you have elders who are trying to escape the nursing home, when really they're just kind of following one environmental cue after another. Right? Right? So when people become executively impaired, the environment starts to control their behaviors. Right? And so people can sometimes relate to this with like alcohol use disorders. So in San Antonio, every year at 3 in the morning, an officer will have pulled someone over on the interstate and pulled them over, and the officer will, their police car, the lights will be flashing, they'll pull them over, and then what will happen is that another driver who's intoxicated will come up behind them, hit the officer, and kill the officer. Right? And people will say things like, well, how could that happen? I mean, the officer had pulled him way over to the side of the road. They had their lights flashing. Like, why didn't they see them? Why did that person, even though they were intoxicated, why didn't they see them? And what's happening is that in the field, those flashing lights are the strongest stimulus in the field. And like a moth to a flame, it just attracts them right into the police car in this situation, right? When I was teaching my daughter how to ride a bike, the strongest stimulus in the field, if you will, was my neighbor's pampas grass bush. So, she's about 4 or 5 years old. It didn't matter where I put her on the street, all paths led to her crashing into the pampas grass bush. It's like she just couldn't help it. Have you ever been to like a high school parking lot, like the student parking lot, where they have like light poles in the student parking lot? Those light poles, have you ever seen them? They look terrible. They're like beat to hell, right? There's like pieces of concrete falling off of them, right? Okay. And again, those are just like the strongest stimulus in the field. You have all these executively impaired, developmentally delayed high school students, not delayed, but developmentally appropriate high school students, and they just hit them. They can't help it, right? They can't help it, right? If you have a driver, a teenage driver, are they more likely to hit another moving car, or are they more likely to hit a stationary object? It's not even close, right? A stationary object, right? And it's like the mailbox calls to you. Bam! Right? And the same is true with elders. Are elders more likely to get in an accident with another moving car or stationary objects? It's the same thing. It's the same thing. Okay? All right. So there's different ways that we will assess executive function. So let's see. So I need here. This will be the audience participation part. I'll do. All right. So let's see here. I'm gonna pick a volunteer. I want the one that asked that question. Okay, you, in the blue, right there. Yep, I know. I'm looking at you. Don't look back. Yep. Can you tell me your name? Can we give her a microphone? This will be perfect. We're going to make you super anxious and test your executive function. Yeah. You just had a cortisol burst. Your hippocampus is transiently impaired. And this is going to be great fun for the rest of us, but not for you. Okay? All right. So here's what I'm going to do. I'm going to give you a letter. I'm going to give you a letter. And I want you to name as many things as you can think of that start with that letter. Okay? So if I said P, you could say people, place, pot, plant. Just whatever comes to mind. Okay? Are you super anxious? Yeah, you are. Good. That's good. That'll be better. Okay, good. All right. So I'm going to give you 1 minute. Yeah. Turn the mic on. Is it working? Oh, there it goes. Good. Okay, so you're going to have 1 minute to name as many things as you can think of that start with the letter A.
Apple.
Go. Keep going.
Apple, alligator, attitude, airplane, audience, anxious.
Good. I'm going to stop you there. That was great. I'm going to stop you. That was all. Thank you. Tell me your name. Tell me your name.
Selena.
Selena. Are you from McAllen?
Yes, originally.
Okay. Selena from McAllen. Thank you so much. That was very good. I'll take the microphone. Okay, so when we test executive function, what we do is we force people to solve problems by breaking habits. So you don't have a habit to come up with words that start with the letter A, right? But as you're sitting there trying to come up with all these words that start with the letter, unless you had obsessive compulsive disorder, but that would be a whole different thing. Okay. So, yeah, right. So this is this is a problem-solving task, right? It's not a memory task. It's not that you've forgotten words that start with A, right? It's just, oh, let me hold it for just 1 minute. I'm going to have another one. It'll be fun. Now they're all nervous. So this is a problem-solving task. It's how many words in 1 minute can you come up with that start with the letter A, right? It's a problem-solving executive function task. If you can come up with 10 or more words in a minute, then you're doing pretty good, right? So this is like anybody in this room can do this. It's just, and so instead of asking your clients what the date is and who the president is and what they ate for breakfast, things that don't correlate at all with self-care, see how many words they can come up with in a minute that start with the letter A. Okay, and this also holds for Spanish. Just so you know, I know this is, it's also been validated in Spanish. Okay, so so that's that example. So let's do another example. So let's see here. Can you tell me your name? Jessica. Where are you from, Jessica? From Edinburg? Oh, good. Oh, very good, very good. Okay, Jessica. So here's what we're going to do. I'm going to say some numbers and letters for you like this. Are you ready?
Okay.
1A, 2B, 3, what would come next?
C.
C, that's exactly right. That's exactly right. Okay, so now Jessica, what I want you to do, I want you to do the same thing. I want you to start with the number 1 and just keep going until I say stop.
1A, 2B, 3C, 4D, 5E.
Perfect.
6.
Stop, stop, stop. That was perfect. Jessica, that was the best that's ever been done. That was that was really good. Okay, so Jessica, how old were you when you learned the alphabet? 4. Yeah, that's right. You're about maybe even younger actually. Well, especially if you grew up in Edinburg, they have awesome schools in Edinburg. You might have been 3, right? Okay. So that's right. You learned the alphabet when you were 3 years old. So 3 or 4-year-olds can say the alphabet, but do they know what a letter is? No. So that's why you'll ask a 3 or 4-year-old to say the alphabet, and they'll start to blur the letters like a word, like elemental P becomes a word, not L, M, N, O, P. So saying the alphabet is actually a habit. It's a habit. How old were you when you learned to count to 10? Yeah, like 2 or 3, probably 3, about the age of 3, maybe 4, but 3. In Edinburgh, definitely 3. Good schools in Edinburgh, so probably about 3. So counting to 10 is also a habit. Children learn to count to 10 before they know what it means to be a number. So you can take a 4-year-old, you can put 7 marbles on a table, and you can say, how many marbles are there? And they'll do one of 2 things. They'll either say, I don't know, or they'll say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Right? So counting to 10 is a habit. Saying the alphabet is a habit. And so what I'm challenging you to do is to solve the problem by breaking these habits. So if you struggle, as executively impaired patients will do, where they'll go 1, A, B, C, D, they just follow the habit, or 1, 2, 3, 4, 1A, 1B, 1C. It's not that you've forgotten how to count to 10. It's not that you've forgotten the alphabet. It's just you cannot break the habits to solve the problem. Right? So this isn't a memory problem, it's an executive function problem. Okay? So here, we'll do the whole audience this time. This will be fun. This is always fun for me. It's never as much fun for them. Okay, so what for the audience, let me see if I can get the mouse here. There we go. Okay, so for the audience, your choices are green, red, and blue. What I want the whole audience to do as quickly as y'all can is I want you just to tell me the color of the squares. So you're going to start here, and you're going to say the color, the color, the color, the color, the color. You're going to come back down here, and you're going to finish here. Okay? So all together now, we're just going to say the colors of the squares, starting at the top and finishing at the bottom. As quickly as we can. Ready? 1, 2, 3, go! Green, red, blue, green, red, hey, that was good. That was pretty good. Now, I heard them way louder than I heard y'all. Okay, y'all have to play too. Otherwise, I'm going to pick on you individually. You don't want that. That was good. Okay. Now, the next thing I want is for y'all just to read. You're just going to read the words, okay? So you're going to start here, and you're just going to read the words out loud. And you're going to start up here, and then you're going to finish down at the bottom, right down there where it says green. Okay? So again, as quickly as you can. 1, 2, 3, go. Red, blue, green, red, blue, green, red, green. Yeah, that was good. Did y'all notice that y'all were faster that time? Yes. Why? Why were y'all faster? Do you know? Because you've had practice? No. The reason you're faster is because you are verbal creatures. Right? Humans are highly, highly verbal. And that's why you were faster. Okay, for the last activity, what you're going to do is you're going to say the color of the letters. So right here, you would not say red, you would say green. Okay? So for now, what I want you to do, as quickly as you can, is you're going to say the colors of the letters. You're going to start here, and you're going to finish down here. As quickly as you can. Ready? 1, 2, 3, go! Green, red, blue. Okay. That's good. That was good. That was good. So, that was good. That was good. That was good. Very good. Very good. But can you feel your brain aching when you do that? So it's not that you've forgotten how to read. It's not that you've forgotten your colors. It's that you are a highly verbal creature, and the habit is to read the word. But there's a part of your brain called orbitofrontal cortex that is saying, if I was holding the brain in my hand, it would be the part, like if I was holding the brain and it's facing toward you, it's that part that is the most polar part of the brain, and then it wraps around and rests on the base of the skull. That's orbitofrontal cortex. That part of your brain is telling you, hang on, you're not supposed to read the word, you are supposed to say the color of the letters. Okay? So the same part of your brain that does that is the part of your brain that governs your poker face. Did you know that? It is. The same part of your brain governs your poker face, right? So like if you're going up Highway 281 and you get pulled over for going, whatever, 70 miles an hour in a 65 mile an hour zone, right? There's a part of your brain that wants to rage, right? You've been pulled over, you're going 5 miles over. What do you want to do? You want to say, ah, damn it, I was only going 5 miles over. I've been passed by 20 people going twice as fast as I am. I'm on my way to see a client living in neglect and squalor, doing the Lord's work. I can't believe this guy is giving me a ticket. There's a part of your brain that wants to rage. But that's not what you do, right? What do? What you do is you stay in the car, and you get out your license and your insurance, and you say, here, officer, here's my license. Was I speeding? I'm so sorry. I hope you're having a good day. As good a day as mine. Right? That's your poker face, right? So when people become executively impaired, what happens? They lose their poker face, right? So how many times have you heard someone say, I can't wait till I get old and I can just say whatever I want? Right? You hear that all the time, right? So on one hand, yeah, that's kind of cute, but on the other hand, it's dementia, right? It's dementia. That's them not keeping their poker face. So these are examples of executive tasks. The tasks that I'll use in the assessments that I do, the one that I use mostly is called the executive interview, the Exit 25. This test is scored from 0 to 50. The higher your number, the worse you're doing. Young adults will score like a 4 on this test. And every 7 points is we see advancing levels of care. So healthy elderly retirees will score 8 to 14. Assisted living, people living in assisted living facilities will score 15 to 22. Nursing home levels of care will be 23 to 30. Locked Alzheimer's units would be like greater than 30. Okay. So when my oldest daughter was 4 years old, she got a 24 on the exit. Okay. When my oldest daughter was 24, she got a 24. When my oldest daughter was 4, she got a 24 on the exit. So when my oldest daughter was 4 years old, was she managing her medications? If she got sick, was she managing her medicines? No. Was she managing her money? She wasn't paying her own daycare. Was she bathing? She bathing herself. There's some mixed opinions here. Okay, so when my oldest daughter was 4 years old, did she ever say, hey Dad, it's 7 o'clock, I'm going to go take a bath, I'll be down in 20 minutes? No, right? That never happened, right? No. So I'd have to 7 o'clock, it's time for bath, I have to go up, I'd have to get the water. I can put her in the tub, I can walk away. She's not going to drown, right? But when I come back 10 minutes later, has she already shampooed her hair? No, I say, what have you been doing the last 10 minutes? And then I have to shampoo her hair and, all that kind of stuff, right? So there's a difference between being able to be in a bathtub versus bathing yourself, right? It's all about the verbs, right? There's a difference between being able to be in a tub versus bathing yourself, just like there is a difference between having money and managing money, okay? So the truth is, when my oldest daughter was 4 years old, she was dependent in both instrumental and basic activities of daily life, right? So she required a nursing home level of care, right? 4-year-olds require a nursing home level of care. But when my oldest daughter was 4 years old, how was her memory? It's good, right? 4-year-olds can learn new languages effortlessly, right? Effortlessly. How was her psychomotor speed? Was she arthritically slow? No. How was her vision and her hearing? They're perfect. They're better than mine, right? How was her her medical comorbidity burden? You'll just have to trust me. She's completely healthy. She doesn't have asthma, right? None, right? So vision, hearing, memory, psychomotor speed, medical comorbidities. If these things predicted self-care ability, then the world would be ruled by 4-year-olds. Because they are better than us at all of those things, right? But the world's not ruled by 4-year-olds. How come? Because they cannot plan, sequence, monitor, inhibit behaviors, right, to save their lives, right? Right? So how old are we when our frontal lobe finally becomes developed, and that last neuron synapses and myelinates, and we're now fully developed, right? How old are we? You know? How? 25. That's exactly right. 25. 25. And if those of you that have teenage drivers and then they go to college and they're being insured, you know exactly what happens when your kid turns 25. What happens? Those car insurance drops, right? So like car insurance companies know the dysfunction of 16-year-old. All right. So one of the ways that we'll kind of assess executive function is that clock drawing test I showed you. Draw me a clock that says 1:45. Set the hands and numbers on the face so the child can read them. So you can kind of see, like right here, you can see examples of bad clocks, of executive impairments. So here, that kind of looks like a face, right? And that kind of looks, that is a face, right? So the instructions are, draw me a clock that says 1:45, set the hands and numbers on the face so that a child can read, right? And you can see right there, they're perseverating on face, right? That's an executive error. They're perseverating on face. Here, I already showed you that one where the habit just doesn't stop and they just keep going. Here you have an arrow. See that arrow right there pointing inward? Right there. Right there over here. Here, see that arrow pointing inward? Why did they do that? Why did they put an arrow? What's up with all that? Why did they do that? They have an arrow pointing inward. They have all these arrows. Why did they do that? Whenever you see arrows pointing inward and all these arrows pointing out, you'll see a big dot in the middle. That always comes with a big dot. So what will happen is they'll draw a circle, and then they'll put a big dot in the middle. And that dot just starts to control their behaviors. They start to draw arrows coming out of that big dot. They start to draw arrows pointing to the big dot. That's the environment controlling behavior. So here's the task. This is just an example of the task. So this is the front of the form we use, this is the back of the form. What I want you to see here is that when you turn the form over, that big circle right there bleeds through to the back. See that? That big circle, if you turn that blank page over, it'll bleed through to the back. And so what we'll see is that you can see they drew, here they're drawing their clock over that bleeding through circle. See that? That's where the circle would be bleeding through on the back of the form. So when you turn that form over, that circle bleeding through is the strongest stimulus in the field. And it just attracts it. It just attracts it. Right? So these are all APS examples. Mini-mental, it's almost perfect. They have a perfect memory score, and they fail the clock drawing test. Right? I've already shown you that one. So here their memory's terrible, their mini-mental's bad, they have pain cortical, right? cognitive impairments. So here's the lady, I showed you this in the first hour, the lady that was living in filth and squalor. Her memory is perfect, her mini-mental is perfect. She fails the clock drawing, and her exit is 2 points worse than my daughter's when she was 4 years old. Right? If you left a 4-year-old by themselves in a house for a year, what would it look like? Right? It'd probably look like that. So these are my kids. I have 4 kids. So you say, "Oh." But if you ask APS about kids, they're funny about that. They have different opinions. They kind of divide in half. Adult protective services, they kind of divide in half. Half of them will say, yeah, you want to have a lot of kids, because if you have a lot of kids, when you get old, at least one of them will take care of you. And then the other half of APS workers will say, no, you don't want any kids at all, because when you get old, they're going to take your money, they're going to take your car, they're going to tell you where to live. So these are my kids. So like, who here has capacity? Right? You can start to think about, who has capacity? Megan, Ellie, Austin, or Kevin. Who has capacity? So when my oldest son was 7, he drew a clock that said 1:45. As Kevin, he was 7, 1:45. Right? His mini-mental, he's passing. That's a passing score on the mini-mental. But you can see he fails the executive measures. When I ask him to say how many words he can think of that start with the letter S, the 3 letters you can use are F, A, and S. F, A, and S are the 3 letters. He gets 2 words, right? So Kevin needs an assisted living level of care, right? He needs at 7 years old, he needs assisted living. This is my daughter, my oldest daughter, now she's 10, right? She's 10. She's a 27 on the mini-mental. She's passing clocks. One of the mistakes she made is that she put a 1:45 up there because she thinks I'm going to trick her. So I give her the instruction, say, "Oh, I'm not going to let you trick me. I'm going to put a 1:45. That way I'll have documentation of the time." So she's smart, right? Her exit is an 8. She now gets 14 words that start with the letter S in a minute. 14, right? Her exit's an 8. So she's scoring the healthy, elderly, retiree level of care, right? So if you put my 10-year-old in a senior living community where they had weekly housekeeping, weekly laundry, communal meals, and transportation to Walmart, she would be fine, right? She could live like that, right? So again, when you start to think about what predicts self-care, it's executive function, right? Executive function is what determines level of care. It determines it's stronger than the number of medications that people take, their mini-mental scores, their cumulative illness rating scale, which would be medical comorbidity burden. It predicts it's stronger than their age or their education. What predicts level of care is executive function. Let's get through some of that. So as a case example, this is an 88-year-old Hispanic woman who's referred for neglect. It's a recidivistic case. She lives on the west side in San Antonio. Her house is in severe disrepair. It's squalorous. Animal feces throughout. APS discovered a dead dog in the home, actually. The primary care doctor knows the patient, believes that she might have capacity, and on the statement said, well, she misses appointments, but she takes her meds. She has bad hygiene, but I think she has capacity. So the primary care doctor, he's not certain. Okay. The family lives in Austin, and they're either they're underestimating the health or safety hazards, or they're overestimating her abilities. So like 4 days prior to when I went there, they showed up and they gave her a broom. They said, here, there's a broom. If you can sweep this place up, okay? The utilities are being disconnected. APS has had to pay them. They've been reconnected multiple times. Previously diagnosed with dementia, but don't know more than that. Other medical history, medications are really unknown. So this is all the information I'm getting from APS as we're driving there in the car. She's from San Antonio, 4-year degree in sociology. She's been divorced more than 10 years, no children, no tobacco, alcohol, drugs, earns $550 a month, has Meals on Wheels. We go into her home. Let's see here. So this is her bedroom. Like her bed, it's not made. There's just garbage and stuff everywhere. This is her refrigerator. It's full of meals. Those are all Meals on Wheels containers. She just kind of eats a little bit and puts it in, eats a little bit, puts it in. They just start to pile up. You can't really smell the picture, but those of you that work for APS know exactly what this smells like, right? This is her toilet, right? So the toilet's not working, it's overflowing, it's all feces in there. She's feces and toilet paper there. I thought about developing a collage titled Toilets of South Texas. And I'm just taking pictures of this. But anyway, this is me. So keep in mind, the family shows up and gives her a broom, right? The family says, you know, she just needs a broom. Okay. So when you think about this client, you know, what kind of risk, are there any modifiable risk factors for future neglect? Is there anything that APS can do to help her not fall into this self-neglect mode? Is there anything APS can do? Is there anything modifiable? What's that? So they can recommend, that's right. They can say, you know, it just seems like this house is too much to manage. Maybe an environment that has housekeeping would be more helpful, right? They might suggest provider services. They could. I'm not saying they would, but maybe provider services is what she needs. What are risk factors for neglect that she does have family, so maybe just educating the family would be helpful, right? What are risk factors this client has for neglect that APS really can't do anything about? They're non-modified. So maybe she has dementia. There's nothing APS could do about dementia. That's right. So APS, the option that they exercised was to call me because there's the primary care doctor is just uncertain. Right? This is just the battery, the neuropsych battery that we use. I've already gone over all of this. We do the memory impairment screen, the mini-mental, 2 measures of executive function, including clock drawing. We always screen for depression, right? We wouldn't want to miss that. We wouldn't want to ever suggest that someone has incapacity when it's really depression. So we're always going to make sure they don't have depression. If you look at the APS data here, the only thing I want to show you on this very busy slide is that half of the patients that I see, half of APS clients that I see half fail the mini-mental. Half of the APS clients that I see fail the mini-mental, which means that half pass it, right? Half of them pass the mini-mental, right? But when you look at the executive measures, 90% of them are failed, right? So the mini-mental is not a capacity instrument. It was never designed to be a capacity instrument. The mini-mental is not a capacity instrument. What we know in our APS data is that the executive measure, especially the exit, predicts a third of the variance of clients' abilities to manage their money and another third of their abilities to use a telephone. Right? 37% of the variance to use a telephone. And none of these other measures correlate in multivariate. I don't want to torture you with statistics. I'm going to skip through that. The other thing we know, what we also want to predict is survival. So do these neuropsychological tests predict survival? Because we're having to decide, is the situation so bad that we should remove this elder from their home, right? So what predicts survival is copying a clock. Not executive function. So executive function predicts your ability to care for yourself, but what predicts survival is copying a clock. And this has been replicated over and over and over again. Here it's being replicated in an APS sample. So if you kind of look at the 500-day mark, what this tells you is that 500 days is about a year and a half, right? That's about a year and a half. The red line is the group that cannot copy a clock. The blue line is the group that can copy clock. These are just looking at a clock and copying. At a year and a half, if you cannot copy a clock, 25% of non-clock copiers will be dead a year and a half later. 25%. Compared to about maybe 8 or 9%, right? So clock copying predicts mortality. So going back to our case example, her memory impairment screen, it's okay. She has some memory impairments. That's a fail. Her mini-mental is an 18, as it turns out. Her clock copy, or her executive clock drawing, she fails that. She fails clock copying. And her exit is 4 points worse than my 4-year-old daughter's was. Right? And again, if you left a 4-year-old in a house by themselves for a year, you know, what would it look like? Right? What would it look like? So that's our cases example. So now you tell me, does that client have capacity? So in your mind, does the case we just discussed, do they meet this definition? Yeah, right. So this is an example of an incapacitated client, right? She has dementia. She has all these cognitive impairments. She's not taking care of herself. The cognitive impairments, in my opinion, are mediating the disability, and she doesn't have capacity. So one thing adult protective services can do is they can just give a heavy clean. They can just say, we are going to clean your house up. So what if APS did that? What can you predict would happen? They'd go right back to it, right? So someone with that bad of cognition isn't going to be able to use these lesser restrictive offerings from APS. What can we predict about her ability to manage her finances? The utilities keep getting turned off, turned off, turned off. APS can just pay the electric bill, pay the water bill, zero out those balances. Should they do that? Is that a good use of resources? No, because for the same reasons, right? It'll repeat. What can we predict about her survival? Right? Not good, right? And so what's the next step? Like, what do we do now? Yeah, the dad's table, refer to guardianship. Right, that's exactly right. That's exactly right. So this is an example of a case that I would do an emergency removal. This is a lady living in filth and squalor and feces, and she's severely demented. And this is an example of a case where I would say, you know, the risk is just too high, and the recommendation is for APS to remove the client from her home, have her medically cleared, place her in a nursing home, and let the judicial system refer to dads for guardianship, and then let the judicial system decide decide the case, right? Decide the case. And I can tell you that when I do these cases, you know, who is it that decides if this woman gets to return home or not? Is it me? Right. It's not me. It's not APS. It's not the Department of Aging and Disability Services. It's the judge. So the job of the judge is to decide how much risk society is willing to tolerate. That's the job of the judge. Okay? How much risk is society willing to tolerate? And I can tell you, of the 20 counties that I go out to, different judges have different ideas. And I'll see every permutation. So like in Barrett County, probably the most common thing I see in Barrett County for cases that warrant guardianship are that the judge will say that the client doesn't have capacity for anything other than to vote. Right? I'll see that. They can't decide where they live, they can't marry, they can't enter financial contracts, they can't drive, they can't manage their medicines, but we're going to keep their right to vote. And the judges, in their eyes, they kind of see that as sort of respecting the dignity of the elder, right? Respecting the dignity of the elder. Yeah. Serving on a jury, yeah, I don't know about that. So that's a good question. That's a good point, right? And I've seen other cases where they'll say the elder doesn't have capacity to do anything other than to drive. I've seen that, right? And so the job of the judge is to decide how much risk society is willing to tolerate. And you know, in Texas we elect our judges. And so if the citizens decide they don't want demented elders driving through school zones, well, then they can elect a new judge, right? That's how Texas works, right? So it's not up to me, it's not up to APS, it's not up to dads. Ultimately, it's up to the judge. So this is, we have time for one more case. So this is a 59-year-old black female. Now she's paralyzed. She's been paralyzed for 15 years. She has incredibly limited use of her upper extremities. She can kind of move them a little bit, and her lower extremities, she essentially cannot use her lower extremities. So she's essentially a quadriplegic. She moved to San Antonio. She lives in a house with provider services, but she keeps firing the providers. So she's a client who just fires and fires. She just cycles through providers, right? Cycles through them. She's only 59, and her providers, she just rides them, and then they either quit. More often, though, she fires them. She has all these bed sores. She's bedridden. She has all these bed sores, and she can't care for her. She can't or doesn't care for the wounds. So there's like this vacuum that needed to be used, and she just wouldn't do it. 2 years ago, 2 years prior to me seeing her, one of the wounds was discovered to be severely infected, had maggots crawling all in it. She was in bad shape. 2 years ago, keep in mind, she was 57. Her primary care doctor is just frustrated. The client just seems ambivalent. She's not using the wound vacuums appropriately. She calls 911 all the time. All the time. In Bexar County, the judge has a task force for frequent 911 callers. These are people who call 911 like 100 times a day. Okay? So she will call 911, and they'll show up, and she'll ask them if they can light a cigarette for her. Right? She just calls 911 relentlessly. She calls state agencies, right? So if she's not happy with APS, she'll call different agencies. She'll call the main office. She always reports up. She owes $13,000 in taxes. Neighbors are kind of feeling like they have to look at her, that she might not do well. Her home is poorly maintained. It's cluttered, like the fence in the backyard is falling down. Wood is rotting. Refrigerator's crammed with rotting food. Kitchen's messy. You couldn't prepare food in that kitchen. And so APS put her in assisted living. They said, okay, you can't live here. Would you be willing to go to assisted living? And she said, sure. So she went to assisted living, but within like 2 hours, she was demanding to go back to her home. And now she's calling the state, saying she's being kept in assisted living, against her will, that kind of thing. The social worker there says that the patient just has a difficult personality. She requires extensive hands-on care. It's just kind of, the patient just has this constant, I hate you, don't leave me mentality. Okay? I hate you, don't leave me, right? Her moods may be improving, it's hard to say. But she doesn't seem confused or disoriented or cognitively impaired. So we interview the client. She says that she needs help, but her preference is to continue to live in her own home. She says that she's been at the current facility for a month, and it was difficult, but now maybe she's thinking they treat her okay. She says her income is $723 a month, and that exhausts all her finances. Just a comment on $720 a month. Whenever I give this talk a lot to attorneys. And whenever I talk to attorneys, one of the questions that they'll ask me is, does it take more? It has to do with how much capacity it takes to manage money. So they'll ask me a question that essentially is sort of like, they'll have a client who has a $50 million estate. And does it take, do you have to have more capacity, more cognition, more whatever to manage these, a $50 million estate, right? And implying that maybe you don't have to have as much capacity for lower. And I always tell the attorneys that, you tell me what takes more capacity, what takes more brain power? Does it take more brain power to live off of $5,000 a month or to live off of $700 a month? Right? What takes more brain power? And that usually shuts that down. All right, so let's see here. She knows that she owes property taxes, but she can't figure out a way to pay them. She knows that she has these medical conditions of paralysis and her other medical conditions. She understands that she needs help with hygiene and cooking, cleaning, laundry, and transportation, but she keeps firing all the care providers. Her past medical history is significant for the injury that caused the paralysis. She's on those medications. Norco is an opiate for pain. She's on Valium as a muscle relaxant for the contractures associated with the paralysis. Baclofen, another muscle relaxant. She's on, the morphine causes constipation, so then she has to have Surfac, that kind of thing. when we do the cognitive testing, so we can't do it all, right? She's paralyzed. So there's a lot of the cognitive testing that requires you to use your hands and that kind of thing. So she's definitely oriented to time and place. Her memory's fine. Her concentration is intact and rolled backwards. And her executive processes are pretty good, actually. She's really not cognitively impaired, right? She's not. She's not substantially cognitively impaired. So does she meet this definition? So physically. What about mentally? Judges won't really award guardianship for just physical, right? Not really. Does she meet this definition? Does she have a mental condition that substantially renders her unable to provide food, clothing, shelter, manage her finances, care for her health? What is it? Like, what is her mental condition? So that's what she had. I mean, those are the symptoms that she has, right? Right? What is that? That's borderline personality disorder. Right? That is borderline personality disorder. So I think when we think of capacity, a lot of times for capacity we're so focused on cognition, cognition, cognition. So dementia can certainly incapacitate a person, but can psychosis? Yeah, psychosis can. Can mood? Can someone be so depressed that they're unable to do those things? Sure. Or can someone be so manic that they're unable to do those things? Can drugs and alcohol incapacitate a person? And I think personality can too. Personality disorders can too. So capacity isn't just, I'm a geriatric psychiatrist, I'm very focused on cognition and cognitive disorders, but people can be incapacitated from other mental conditions, right? And just as there might be reversible causes of dementia, there can also be potentially reversible causes of incapacity, right? So maybe once this person, under a controlled environment, starts to establish trust, forms relationships, then maybe she's able to transition back to independence, right? Maybe it's just, maybe it's reversed. All right. So I think with that, I'll stop there and we'll ask questions. Any questions? Got the microphone passer. Questions about that? Capacity assessment.
Is that one working? Yeah.
There we go.
Is there such a thing as partial incapacity?
So is there such a thing as partial incapacity? That's an excellent question. And boy, I tell you, I'm going to take a lot of heat for this. You asked the question. You went right at it. Is there such a thing as partial incapacity? So, you know, what I can tell you is that, so I have two thoughts on that. Can someone be partially incapacitated? So, I can tell you for almost all of the clients that I see, I would say like 95% of the APS clients that I see where I don't think the client has capacity, I say total incapacity. And that's what I see in my, like in real life, in my clinic. So how often, how often in my clinic do you think I tell a patient, I don't think it's safe for you to be preparing your own meals. I don't think it's safe for you to be using the stove and the oven, but it's still okay to drive. Like that never happens. You know, I don't think you have the cognition that it takes to manage your money, but it's okay for you to still manage your medications, right? That never happens. So what we know about the brain is that it is organized in circuits, right? It's organized in circuits. And once the circuit goes down, then people become incapacitated across multiple functional abilities. If that wasn't true, what that would mean is that the brain is organized in regions and not in circuits. And so this is the financial capacity part of the brain. And this is the medication capacity part of the brain. And this is the driving capacity part of the brain. But that's not how the brain works. The brain's not regional. Because it's in circuits, when people become incapacitated in one thing, they virtually always become capacitated in everything. And even if there's not evident disability in those other areas, it's because it's their habits and their routines that are sustaining them. It's not because they're freely choosing, right? However, that being said, I do think there are times when people are partially incapacitated. That's right. It has to do with the cases that I see most often that are like that are it's when I think that they're only financially incapacitated, but they can still make decisions in other parts of their lives. So probably the most common scenario is the lottery scammers, right? It's where people have given thousands, if not hundreds of thousands of dollars and lottery scams, and all of their disability is focused on that the financial disasters in their life. But when you look at every other piece of their life, their home is clean, they're going to their doctor, there's been no driving issues, it's isolated to financial. So the only time that I ever say that someone has partial capacity is it's almost always in situations like that. Almost always in situations like that. Otherwise, I can tell you 95% of the time, I'm checking the totally incapacitated box on the CME. Yeah. I can tell you what the judge hates. Because I'll tell you what the judge hates. What the judge hates is this, where the doctor will fill out the CME form and say that the client doesn't have capacity for anything other than their medical care. Right? I mean, that's what, and a lot of times it's primary care doctors who'll do that. And it's because they're afraid from a risk management point of view. They're afraid of saying that they've been practicing medicine on someone who doesn't have the capacity to consent. But that's not, but judges they're not going to go after the physician. That's not what they're there for. So what frustrates the judge the most is that, when they say that the client can't do anything but manage their medical care. Whatever that's for. Any other questions? No? All right, well good. Well, I guess it's, is it lunchtime?
Yes, so we are going to break for lunch. It is 12:05, so we're going to start again at 1:05.
Good.
Sounds great. Okay, here are the instructions. Hold on, everybody grab your seats real quick. Here are the instructions. Yeah, more rules. Here are the instructions for lunch. We're going to have the left side of the room. We're going to release them table by table to come around and pick up your drinks and pick up your lunch and circle back around and find your seats again if you want to sit in the same place. And we're going to come across slowly from the left side of the room all the way to the right. There's plenty of food for everyone. Don't panic. I see the eyes, blood sugar's dropping. Okay, don't worry, we'll get to you. There's plenty of food, there's plenty of drinks. So we're going to start on the left, and then we'll end up on the right. So just bear with us, and we'll get everybody's food as quickly as possible. Yeah, make sure nobody...
Won't you see about me? I'll be alone, dancing, you know it, baby. But tell me your troubles and doubts, giving me everything inside now. The love string, so real in the dark. Think of the tender things that we were working on. The slow change will pull us apart. When the light gets into your heart, baby, well, don't you forget about me. Don't you forget about me. Will you stand above me? Look my way, but never love me. The rain keeps falling down. Will you recognize me? Will call my name or walk on by me. Rain keeps falling